I would like to invite the chairpersons, Dr. Preeti Shankar, who's the consultant physician and diabetologist at Apollo Clinics, Bengaluru, past president of FPA and vice president of FFPI. Also would like to invite Dr. V. Prabhakar, who is the general physician, Bengaluru, president of FPA, Bengaluru. We welcome you on stage, chairpersons. We can have a round of applause.
Yeah, at the outset, I would like to thank Dr. Srinivas Murthy for inviting us to chair the session. And I also congratulate him for selecting this topic. We all know that urban cities, there is no dearth of doctors, there are no dearth of clinics, and there is no dearth of tertiary hospitals. But what is required is in the rural setting. And in the rural setting, we also know that today, diabetes is catching up very fast, even in the rural settings. And to introduce Dr. Dinesh, I request Dr. Prabhakar.
Hello, good morning everyone. So it is my pleasure introducing Dr. Dinesh Agarwal, MD, and he is currently the head of the Department of Medicine, Marwari Hospitals, and he is Dean and Academic and Research Head in Marwari Hospitals, Guwahati, and National Governing Council member, RSSDI, and he has many achievements to his credit. He is faculty both regional and national in the field of diabetes and medicine, and he has participated as a principal investigator in many clinical trials in nationally and globally. So over to Dr.
Thank you, Chairman, sir. Thanks, Dr. Srinivas Murthy, for giving me this topic. Namaste to one and all. So my topic is diabetes care in rural India. We all know the diabetes, it is one of the most challenging public health problem. We all know it's a chronic metabolic disease, and most common is type 2 diabetes. It's both economical burden and loss of health caused by diabetes complications. We are not worried about only the number. It is the complication which we are worried about, and the primordial as well as primary prevention and early intervention in diabetes management, which we want to do it. So what happens? Uncontrolled diabetes leads to both short-term as long-term complications. This is the cartoon which you see regularly. Heart failure, type 2 diabetes mellitus, ASCVD, and CKD are the interrelated disorders with many stark risk factors. Patients having one disease are at a risk of the others, and it is a multi-morbidity is very common. So what we can see is that 8.7% of the Indian adult population have diabetes, 32% of the patients having diabetes have CAD, and 12 to 45% patients having diabetes has heart failure. 60% of the patients who are heart failure had diabetes and CKD, and around 40% subjects have heart failure as well as CKD. So this is the complications we do. If we talk about the diabetes prevalence in India, the ICMR, the famous in-depth 17 study 2023, has shows the overall prevalence of in 2021, which is around 11.4% of diabetes. Urban prevalence was found to be 14.2%, vis-a-vis rural prevalence at 8.3%. Pre-diabetes is much more. It's a volcano which is about to bring. So sometimes it thinks we diabetologists, 11.4% million people are with diabetes and more numbers are with pre-diabetes. So volcano will keep on rising. States like Punjab reported high prevalence around 19%, with rural states shows rising rates. It reflects the increasing diabetes spreads into the undeserved area also, underserved area also. In 2021, we have 101 million people and 136 million people having the pre-diabetes. Now, these cartoons is the rural Indian lifestyle and prevalence. It's from Haryana. The prevalence was found to be 9.5%. The risk factors we can see unhealthy diets and lack of awareness was much. If we vis-a-vis compare with the urban India, the obesity and physical inactivity remains the number one for these subjects. If you see the trends in prevalence of diabetes and pre-diabetes in urban versus vis-a-vis rural area, and if you see the 1972, down the line 27 years, it was 2.4% in the rural versus 3.3% in the urban India. But what we can see is data from the 2015 to 2019, it is around 15 and 19% respectively for the pre-diabetes and diabetes. The data has increased from 2.4% to 15%, from 3.3% to the 19%. So higher prevalence of diabetes reported in the urban populations and their rural, in comparison to the rural counterparts. The difference is mainly attributed to the more sedentary lifestyle in the urban, worsened by the access to the high calorie processed food, increased stress in the urban setting, and environmental factors such as the air pollutions. Noise pollution is also there nowadays, which can lead to the multifactorial and the comorbidities and the metabolic diseases. Exposure to the toxins. Rural areas may have a more physical demanding lifestyles and access to the healthier locally sourced foods. There are frequent barriers in accessing healthcare services in the rural area due to the geographical distances, limited healthcare facilities, and the workforce shortage. Nobody wants to go to the rural area. Everybody wants to settle in the Bengaluru or in Guwahati or in the Calcutta, in the metropolitan city, whoever pass out from there. Their lower socioeconomic status in the rural area attributed to the lower average income and lead to the, again, reduced access to the education and the employment opportunity. Again, this cartoon shows the urban and rural differences in the new onset type 2 diabetes patient, comparison across national and the regional samples in the diabetes lead network. There are regional and the community type specific risks for the development of diabetes, independent of the individual risk factors. In the south, the likelihood of the new onset diabetes was higher among those residing in the rural communities. And this year, the adjusted association of the community type with type 2 diabetes mellitus is the study model and adjusted for the female sex, including quadric age in VDR sample, and also adjusted for the race and ethnicity. Now, if you see the prevalence of diabetes complications in the rural India, this data shows that it is increasing, whether it's a diabetic retinopathy, whether the peripheral neuropathy, diabetic microalbuminuria, renal insufficiency, peripheral artery disease, and CVD. Now, what is the difference between the rural versus urban in the diagnosis as well as the control? The difference in the diabetes care and control in 42 low and middle income countries, this cartoon shows a cross-sectional study of the nationally representative individual level data. These are again age adjusted proportion of individuals with diabetes achievement performance measures are calculated as a predictive margins. So we can see that ever tested population awareness, it is much lower in the rural population, whether it is a ever tested awareness, glucose lowering medicine or blood pressure lowering medicine or statin, which we call ABC. Then we can see that the glycemic control, blood pressure control, and the cholesterol control are much lower. And if we talk about the combined ABC control, it's much lower in the rural population in comparison to the urban populations. Individuals having diabetes in rural compared with urban area in the low middle income countries are less likely to achieve performance measure for diagnosis, treatment, and control and associated cardiovascular disease risk factors. This D5 composite metric was met in around 39.9% of the rural population in comparison to 43.2% in the urban population. Rural patients, type 2 diabetes patients were significantly less likely to have attended all metric goals than their urban counterparts. Rural group have fewer OPD visits and less often had an endocrinology visit, which has been seen in these studies. Now, if we talk about the national estimates of the adult diabetes care continuum in India, proportion of the respondent whose diabetes have been previously diagnosed was higher in the urban areas, around 77.2% versus rural areas. Among those who have previously diagnosed diabetes, the proportion who got treated are again higher in the urban area vis-a-vis the rural area, which is around 70% versus 52%. Among those who previously diagnosed diabetes, proportion with controlled diabetes was higher in the rural areas versus in the urban areas. Again, self-care practice, we all see it is to be self-managed, it has to be individualized, and it has to be patient-centric. So, what comes when we do the self-managing? It is the capability, motivations, and opportunity. So, what we do have psychological community, we have a limited understanding of diabetes in the rural area. Beliefs in the alternate therapy is much. They believe and they always think if they start medicines, their eyes will go away and that will be the last stage. And they always think, I have a marriage in the house, we have a festival in the home, so I have taken lots of sweets. That's why my sugars are high. So denial phase is there. So attitude to our diabetes is there, fatalism and negative attitudes, drug side effects, they always think of, whenever you write a prescription, I think everybody has seen this scenario, whenever you write a prescription to any of the subjects, they will ask you, Doctor Saab, iska koi side effect to nahi hai, whether they have side effect or not. They will take whatever they want to do, but they will always ask you whether there is a side effect or not. There is a misconception. Then physical capability and comorbidities, then motivation, diabetes mellitus related symptoms and complications, preference and needs to improve diabetes self-care, there should be automatic motivation and perceived self-efficacy. There may be a physical opportunity. In rural area, there may be a financial constraint. It may not be for every state, but in general, I said, time constraint, weather constraint, availability of medicines and diagnosis services, and the diabetic educator. Nowadays, in our busy practice, we do not educate our patients. Most of the time, we hire a diabetic educator. In rural area, that may not be possible. If we do not teach our patients, it's very difficult to make them understand that how to take medicines and what are the complications they should take it. There should be a social support also, family support, physician guidance. Our role as a healthcare profession is a must. We should give more time to our patients, at least at the beginning or 1 or 2 settings, to make them understand that this is a lifelong treatment. Diabetes is not going to be outdated. Everybody thinks you have given a medicine for 1 month. They will say, I have completed your course and I have stopped medicine. They will come back to you with some complications after 1 year. So all this is needed for the diabetes self-care behavior. So how to understand? Patient having diabetes and healthcare physicians, rural areas often face unique challenges when it comes to diabetes self-care management. Participants perceive that a limited understanding of diabetes mellitus, which we have discussed, they always believe in alternate medicine. We have a constraint, and participants express need for comprehensive diabetes care through the structured diabetes education intervention to improve diabetes self-care. So, diabetes care in rural India, we have a Chunampet Rural Diabetes Prevention Project, which was a successful model for screening and the delivery of the diabetes healthcare and prevention to underserved rural areas in developing countries like India. It is very much needed. We should try for a primordial prevention. We should have a population approach. We should conduct an awareness program, screening for diabetes and pre-diabetes risk factors, because there is an increased diabetes factors. At RSSJ, they are adopting village of capacity of 3,000 to 5,000 for the regular screening for the primordial prevention. Then we comes to the primary prevention. We should have high-risk approach, lifestyle modification, plus minus metformin. It is up to the physicians. Then if we need to have secondary prevention, we should have once person has diagnosed to have a diabetes, we should have a good control of ABC. Telemedicines, when to screen for the complication should be there. Then we have a tertiary prevention, treatment for complication at local center for early complication, and should be referred in this Chinnamati project. They have referred to the Chennai for the person present. You have to choose your nearest hospital where you are the referral center. Now, ASA workers, they are in rural India, they are a ray of hope for diabetes care. They can play important role, conducting awareness, raising campaign on diabetes generally to prevent the onset of diabetes and its complications. We should identify cases of diabetes within the community and should be referred them to the diabetes care facilities. It should be a targeted screening, blood glucose monitoring, point of care testing that generate diagnosis in real time. Then motivating expectant mothers for blood glucose testing as a part of their antenatal care. Because if we are able to pick up the mothers, expecting mother and the pregnant ladies, we are dealing with the two lives, mother and the baby. This is important part. And we all know at the time of the pregnancy, the programming sets in. We need to do a primordial prevention at that time. We have a oration afternoon here regarding the pregnancy and GDM. So it's very much needed. If we want to save our future generations, we should have a more focus there, and the ASA worker will play a major role there. We should always check on the compliance with diet, exercise, medication, and the blood glucose monitoring. We should allay fears of the subjects and misconception in the persons having diabetes in the rural area with insulin injections. Whenever there is an insulin injection, they will say, this is the last stage, my eyesight will go. We should make them understand this is not something which is you should not take, you should take, this is going to benefit you. Now, what are the current challenges we have? As we have discussed, it is a limited access to the healthcare in rural area. A significant proportion of Indian population lives in rural where diabetes care resources are and specialists are limited. The awareness is only 43.2% of the Indian population is aware of diabetes. With rural awareness, it's much lower than that. So, in any diabetes self-care or diabetes, there should be a 5 pillar. We should have diet, we should exercise, regular monitoring, regular treatment, and the 5th pillar, the most important pillar, is the education and awareness. It is not awareness is only to the patients, it is to the healthcare profession and all the persons who are related to the healthcare delivery, including our diabetic educator, nursing staffs, and all these things. And it required to the pharmacists also. Whatever prescription you write, they will end up into the pharmacies. They will say, oh, don't take this medicine. This is not good for you. And they will believe on that, not on you. There is a financial burden. Diabetes can cost up to 25% of one's household income. So people lives. We have to make sure that we can make available and treatment affordable. There is a high rate of non-adherence. Various studies in India report that 50% of the subjects do not adhere to their prescribed treatment, mainly in the rural setting. There are cultural, traditional, and the dietary influences. So we should take that. We have lots of festivals in India. Harvest season is there. Then we have, today we have Eid, then Sabbath, Gudi Parva. So we take lots of sweets in the name of festivals and name of religions. We should take care for that. So proposed solution, telemedicines and the mobile clinic. We should expand telemedicine services, deploying mobile health units, which can bridge gaps in the rural areas. We should collaborate with the local organization to promote awareness using culturally relevant material. Insurance, this is very much needed. We should advocate for subsidies. There should be a policy change to provide diabetes care under national insurance schemes, reducing the financial burden for the families. We should have a follow-up program by community health workers. They support and influence by following with the patient regularly. This is very much needed. If you give a call, then we should also see the local culture, develop dietary guidelines that account for the regional food, preferences, and lifestyles, encouraging substantially dietary changes. And last, in India, considerable difference exists between the urban versus rural regions with respect of the diabetes prevalence, treatment, and control. There is a need for the targeted, decentralized solution to improve the diabetes care continuum in India to prevent the complications, because we are at the volcano, we are the diabetes capital of the world, and our Honorable Prime Minister on 15th August has also said to cut the carb intake by 10%, oil intake by the 10%. Program and policies should have strengthened global diabetes care. We must consider the unique challenges experienced by our rural brothers and sisters. Thank you very much.
Thank you very much, sir. It was a very interesting topic you very clearly brought out. He has finished 2 minutes in before time.
Thank you.
1 or 2 questions or comments if you have. If there are no questions, we will wind up the session. Thank you very much, Dr. Dinesh.
Thank you.
It was an excellent talk. You brought out very clearly the differences in the rural and urban settings. Thank you very much.
Thank you so much, doctors. Thank you to the chairpersons and speakers. We request you to move to the selfie area, which is rest outside the hall.
Thank the organizers of Violet for the opportunity.